I think you're right. Recreate the spontaneity of the phone call, and people will like that.
All right, Randon. So, I mean, today I wanted to talk to you about something, and obviously it alludes very much to what we've talked about pretty much all the time. But there's a video I saw on social media. I have no idea who this child is. I just want to share it with you right now. I don't know what age he is. I think he's roughly around 9 to 10 years old. And I think the caption of this video said something along the lines of getting some treatment after basketball. It seems that there's some sort of tool that they're using to apply cryotherapy directly to his leg. They've covered it with what appears to be a cast cover. He certainly doesn't look even teenage, maybe 12 at the oldest. I think he was listed as 9, and that's
What do
the
you
video
think's in
there.
that tank? What do you think's in that tank? And then the
So
wall said something like high pressure something or other.
I know. So these are good questions. I don't know. There's not a lot of information that was in the caption of the video. And I think that first and foremost, we should talk about, I'm not entirely sure that I would be convinced that this is doing any harm. It looks like sort of concentrated cryotherapy. And if whoever is administering it has a decent experience with knowing what they're doing and they're watching for, signs of injury, certainly, applying direct cryotherapy to the skin in the format that they're doing could be dangerous and cause skin damage and frostbite. It looks like they've taken precautions and put a cover on. And it also looks like there's a timer in the back of that video. So they're keeping an eye on not doing this for too long of a period of time. But just, walk me through when you see something like this. And I can only imagine that patients who come to see us who have children that are playing sports in this age group, many of them are probably involved in all these sorts of recovery types of mechanisms, either pre-practice, post-practice, pre-game, post-game, on their off days. I think the spirit of what they're doing is probably in the right place, but give me a thought through what you feel this is really doing. Is this helpful? What do you think the pros or cons of this are?
I have a lot of thoughts. So jump in if you're like, one of these thoughts resonates with you. So I guess my initial thought is like before trying to figure out what actually they're doing, it's like, what lever are we pulling with this treatment, right? Like if a kid that age, let's just call them 11 or 12, right? I can't see why an 11 or 12-year-old would need such a treatment to such what I would consider like intense level of treatment. Like I would imagine like, hey, we need to actually figure out why it is you need like aggressive cryotherapy at this point, right? Like, and maybe, they've got a diagnosis or whatever, but I would not want this to be like, hey, come by and get your, cryotherapy. Because I think the question one is like, we're still kind of trying to debate whether this is a useful treatment or not. And I'll say maybe not an 11, 12-year-old, but like with the teenagers that I'm working with, I'm really thinking about what part of the season are we in, right? So if we're in season and we've got a game in 2 days, then sure, like cryotherapy in a safe way, I'm good for that. But if we're out of season and someone's sore after a training session, that's a good soreness. And we don't want to restrict the inflammatory response, the cascade of events that should be occurring. We don't want to block that with cryotherapy. So I guess my first question is like, if this is an injury issue that they're treating, that seems like very, very concerning to me. If this is more of a recovery issue, I don't really get it. I think the risk is way higher than the reward in an 11 or 12-year-old. Right? If they're that sore that they need cryotherapy, like, hey, we need to dial it back a little bit. We need to dial back the intensity. I don't know. This just seems like, I don't want to use the word absurd, but it just seems like way out of proportion to what you would be needing for a kid that age. I don't know.
think
What do you?
you're striking exactly the same chord that I was thinking of striking, and that was my initial reaction when I saw this video. I think what my philosophical approach to this is first, if you're dealing with a child who still has open growth plates, and especially one who hasn't had that pubertal growth spurt and hasn't started to really grow exceedingly during the initial stages of puberty, if you're before that time period, physiologically, I think muscle soreness is not typically experienced in that age group in the way that adult physiology muscle soreness is experienced. And so we know that we have delayed onset muscle soreness, where if you're relatively untrained, you pursue some activity or exercise or sport or training, it's normal as a physiological response to inducing the breakdown of muscle through the process of training that you will develop soreness approximately 12, 24, 36, 48 hours after that training stimulus. That's a normal physiologic response. We feel that pain, typically speaking, mainly in the muscle bellies of the muscles that we have trained and in the myotendinous junctions of the muscles that we've trained. And that's normal. And that's a normal adaptation of the human body. And as you train more regularly, the stimulus is then going to increase in terms of what your muscles need in order to feel the soreness again. And so that's kind of our way of becoming stronger over time and making our muscles and tendons more resistant to injury over time. That feedback loop that leads to the muscle soreness in adults is not typically the way that we think about muscle soreness in children, because they don't experience that same sort of stimulus, because they don't have the same hormonal milieu before the pubertal stages. They don't experience soreness in the same way. And so I'm very keen when I'm seeing kids that come in with pain or what they're describing as soreness, and they look like they haven't quite gone through the pubertal stages yet. And when I ask them and I get more history and I review their growth, they haven't quite gotten to that part of their lives yet. If they're telling me they're having soreness with activity, my radar that this is an injury that needs very close monitoring and diagnosis, my radar for that is quite sensitive, because I don't think of children having muscle soreness regularly after activity as having some sort of simple problem that we should just be doing cryotherapy for. I feel like their body is trying to tell us, I have some issue that I need monitoring of and close guidance and diagnosis, and cryotherapy might be masking some underlying problem that needs to be more urgently diagnosed so that I don't increase my risk of some further injury down the road. Would you pick that up on that if I put that down?
Yeah, and to like jump onto that, to add on to that, it's like, and more so, cryotherapy would not be the treatment that I would be prescribing for the possible underlying issue, right? Like, I would be trying to figure out, like, hey, what's the actual diagnosis here? And I think maybe we can, let's just kind of ballpark and say like 12 and under, right? Like in that age group, there's not this like, hey, I went to the gym and I have this massive delayed onset muscle soreness. At least we don't see that, And so the question just has to be like, what are they treating in this video? And one, if it's recovery, I can't buy. I'm not really buying that. And then if it's two, if there's some type of pain, it's like what's the underlying diagnosis? But I have never heard or have seen this type of treatment in any patient that I'm aware of as a, yeah, I don't know. I'm skeptical.
I agree with you. And I think, to add on to that, you probably, similarly to me, get asked very regularly whether the parents or the patients should be applying ice or heat to certain injuries. And the way that I approach it is evidence to support that it helps something is pretty narrow spectrum and limited, but we apply ice to almost anything that we think might be an injury to the musculoskeletal system, despite the fact that the evidence to support its use is not that robust. From my understanding of the literature on my most recent review, cryotherapy seems to make a difference soon after somewhat acute ligamentous injuries, particularly of the ankle. But outside that very narrow clinical spectrum, I'm not seeing robust evidence to suggest that cryotherapy should be used in some sort of targeted and prescribed manner for most other injuries that we take care of, and especially not so for what we would imagine to be overuse injuries like tendonitis and apophysitis. I usually tell patients and parents, if you apply ice for limited periods of time just to let the child feel better, if they feel better after using ice, I don't think it'll do any harm, but I wouldn't use it as the answer to the diagnosis I'm giving you. The answer to the diagnosis is likely some form of rehab or retraining of the biomechanical pathway. That would be the answer. Do you sort of approach it the same way?
Yeah, I mean, I guess the question I'm always going to ask in anything like this is like, what's your goal? Like, what are you trying to accomplish, right? So if you've sprained your ankle in a soccer tournament and you have a game the next day, then certainly, like, it sounds like the goal is to be able to return to play next day. Like, hey, let's be a little bit more aggressive about icing, cryotherapy, right? Because that's going to give us our potentially a better option in achieving that goal. But if again, like, it's a practice and there's no games coming up, or it's just a training session, maybe we're going to dial that back and say, hey, there's some potential downsides to using ice frequently and allowing the body to just recover on its own. Maybe we don't use it in that scenario because we have a longer window of opportunity to heal. And I think that's how I would approach it, is like, what part of the season are we in? What goal are we trying to accomplish? And everything that's going to be give and take. And my point in this video is like, what lever is that trying to pull, and how big is that lever? I'd imagine even if you were to argue that that was a viable treatment, I can't see that the impact of that type of treatment would be dramatic in a 12 and under kid compared to the risk of whatever it is that they're doing. Just that's my opinion.
Yeah, and I think would you also be okay with saying the ice may inappropriately inspire confidence in that patient that what they're experiencing is normal, whatever this. Let's just say that there is like actual a pain that they're applying the ice for, the cryotherapy for. So we're sending the message to the patient, it's normal to feel this way, and we're going to apply cryotherapy to like numb it at least temporarily, and then maybe that temporary numbing wears off, but there's like kind of a bleed over effect. The child feels better because applying ice frequently makes you feel better, but you haven't changed what you're doing from a grassroots standpoint. You're still doing the same amount of hours of whatever sport you're involved in. You're not changing the biomechanical movements during those sports. You're still experiencing the same sort of discomfort repetitively over time. Do you think that maybe there is an argument to be made that doing this regularly sort of reinforces poor mechanics and poor thought processes about how to approach sport, and then that could lead to a problem that's more difficult to treat?
Yeah, I would not advise routine use of cryotherapy for pediatric patients who otherwise are participating in normal sports activity. My first, second, and third question would be, why are you requesting this? Why are you needing it? That's the approach I would take. I think it's just very, very unusual that a young patient, would need this on a persistent basis. But like, if your goal is to improve mobility after an injury due to pain control, okay. I mean, I think you could ask this same question we're asking about like anti-inflammatories, right? Like, again, it depends. It depends what our goal is. Like, if we're heavily using anti-inflammatories after an injury, we are potentially doing some harm, whether that's to the gastrointestinal tract, whether that's to the gut biome. Like, there's a lot of things that we are working with that we have to think about, not just like, does the athlete feel pain or not? I guess, curious, what you would say to, let's just take hey, it's a 15-year-old with an MCL sprain. You have confidence in the diagnosis. It's not surgical, and you're gonna say, hey, we're just gonna do some rehab, get back to activities over time. And they say, okay, how aggressive do we need to be with the anti-inflammatories? You've told us about your thoughts on ice, but what about oral medications?
That's the second half of the conversation that almost always follows whether I should be icing or applying heat. And my thoughts are kind of similar to yours, and it's almost the same as my cryotherapy thoughts, which is that I don't think there's direct harm in doing narrow spectrum use of anti-inflammatories like ibuprofen and naproxen. And soon after an injury, I'm okay with patients taking it in a scheduled manner for a couple of days. If they're otherwise healthy and they don't have any past medical history, they have normal gut function and normal kidney function, I think making them feel a little bit more comfortable by using the anti-inflammatory effect of ibuprofen would be useful. But however, again, just like ice, I try to emphasize that taking anti-inflammatories regularly is not my treatment for sports medicine and orthopedic problems. It's not the main thing I want you to do. It's not the foundation of what I want to instill in terms of the treatment plan. And I think that I'm very deliberate when I say this because using anti-inflammatories regularly is the foundation of certain treatment plans for other conditions that can look like musculoskeletal conditions caused by sports. So this is like when we would tap on our rheumatology colleagues who diagnose autoimmune conditions, and their first line for pediatric patients for several autoimmune conditions is to take naproxen every day for 2 weeks or 3 weeks. They do use it, but they're treating a different diagnosis that has a different pathway in physiology. So that's why I sort of go out of my way to discourage. Because if I get the story from the family that, hey, we did everything you said, he was still having discomfort and pain, but he started taking naproxen every day for 5 days, and now it feels like he's totally fine. That to me would make me scratch my head and say, maybe I've got the diagnosis wrong. Maybe this is some other condition that's masquerading as a sports condition because the conditions that we are typically in charge of taking care of. We would approach them with a limited spectrum use of those medications, followed by appropriate structured rehab and biomechanical training. And when the way that the patient is experiencing symptoms seems to deviate from our expected treatment pathway, that makes me put in a stop and sort of reassess whether I've got my diagnosis right.
But are we doing harm is the question. Like, are we creating a environment within the body that is improperly, maybe that's not the best word, but is improperly healing the injured region, like this MCL picture? Are you, by telling them early on, and there may not be an answer, I'm just asking because I don't know like the exact answer, but let me just pivot to a situation that I was in. So I was covering a gymnastics event and the athlete injured their ankle, sprained their ankle, but they denied like they did not want to take the ice that was provided by the athletic trainer because of this concept of, blocking the proper inflammatory response to heal it properly. Maybe that would cause issues down the road. So let me put that to you and maybe ask you that in the sense of pediatric versus adult, because I think sometimes there's these concepts that come out from the adult side that is like, yeah, if you smoke cigarettes and you have type 2 diabetes, this is harmful. But on the other hand, it's like, if you're 9, is that really going to make a difference? I don't know. What do you think?
That's a good question, a good perspective. And I think that in order to address it, I'd probably focus on the cryotherapy part of it and give an understanding currently regarding the evidence. So there was a publication, and it was published earlier this year, but because of the recent uptick in the encouragement of people to do whole body ice immersions as a form of either recovery or as sort of a form of like sort of mental training and preparation, the utilization of therapeutic ice baths has gotten very popular within the last several years. Certainly, initially, it seemed to be primarily adults who were interested in utilizing the benefits of ice immersion. And now that seems to have bled over into the adolescent and pediatric population as well. One of the recent studies that was published with really good data overall suggested that if you introduce a very significant training stimulus and you get the body into a pro-inflammatory state, which exercise does cause, it causes the release of inflammatory signals, which are important to physiologically respond to a training stimulus and allow your body to recover, then soon after that training stimulus, if you jumped into ice immersion, that actually blunted that quote unquote good inflammatory response, and you actually had poorer performance over time and poorer muscle growth over time. And so that was kind of an important study because it told people that ice immersion after intense exercise, if that intense exercise was done with the purpose of improving function, performance, and muscle size, I don't think you should be approaching it where you should immerse yourself in ice soon afterwards. If you wanted to use it as a tool, I would use it perhaps before you did your training stimulus. Then after the training stimulus, either stay in steady state room temperature or perhaps even some warm sauna sort of situation. So the evidence this year seems to suggest, at least preliminarily, that utilization of cryotherapy, or at least whole body cryotherapy, should be avoided in circumstances where you've just introduced a training stimulus to make you stronger or perform better, and rather that should be offset from that training stimulus. That's a different conversation than using cryotherapy in response to injury. So if you've got an ankle sprain, the evidence to suggest that using cryotherapy within the first several days after that ankle sprain improves pain control and improves early ankle function, which likely means you're able to do the dedicated ankle rehab earlier, which means your return to sport could be accelerated compared to those who decide not to do the cryotherapy. I don't know of any evidence that suggests that introducing cryotherapy soon after an acute injury in this manner changes the inflammatory response from an injury in a way that impairs ankle function further on. I think that the inflammatory and swelling response after an injury is distinctly different than the inflammatory response that's produced from a training stimulus. That's why it makes sense that with the injury, it's okay to use ice because you're trying to tamp down that inflammatory response somewhat. But from a training stimulus, you want that inflammatory response from exercise to allow unimpeded to get the best performance benefits and muscle size and muscle strength benefits. That's the way that I would
Okay.
approach that.
No, I like that thought process. I think there was also that article, and I can't remember what the whole acronym stood for, but that article that was called like Peace and Love, and it had to do with like how getting away from using cryotherapy, and it had to do with like early motion and all those things. But I think this is the hard sell is like, okay, well, does this perceived theoretical limitation of the body's response from cryotherapy, how does that outweigh against early motion, like loss of muscle strength? Let's say you're like, hey, you're in a boot after an ankle sprain and you're just icing versus early motion. And like, I think there's so many variables there that it's hard to kind of pick out which one's the most important. But I think it gets to like real life too, right? Like real life is people still have to go to school, they still have to get around, right? Like if they're in pain, that can be a big issue. But I think what I get some pushback is, well, will this make me more predisposed to further injuring this ligament because we were, quote unquote, aggressive about the anti-inflammatories up front? I kind of sometimes will just say, like, this is a concept. I don't think there's any clear data one way or another, but we're just going to take it one day at a time and see what we get, as opposed to like, I'm really anti people that are like all or none, like it's only this or it's only that. I think I could see the arguments for both sides, but I think again, it depends on season, time of year, what your goals are.
I'm a big biomechanics guy, and I am consistently sold that when you're ready to return back to sport from an acute or chronic injury, I have not done my job correctly if I'm returning you back with the same mechanics that you had before you got hurt in the first place. I think that this is the same thing for soft tissue injuries like MCL sprains and ankle sprains. My suspicion is that if those are non-contact injuries, then something predisposed you to injuring that specific part of the lower extremity, whether that was poor engagement of the hip muscles, poor core control, poor landing mechanics, whatever the case is. If it's a non-contact soft tissue injury of the lower extremity, there was something that we could have done better to prevent that, or at least decrease the risk of that happening. And so, when I'm rehabbing you back from the injury and the pain is getting better, the swelling is getting better, and you're ready to return back to sport, my hope is that we have, along the pathway of recovery, instilled in you specific ways to approach how you land, how you move, how you flex and extend the knee and the ankle, so that you actually use that extremity better in a more biomechanically sound way with good confidence, so that when you go back, not only are you back playing at the level you were before, you're returning with a decreased risk of injuring that side again, or even injuring the other side that never was injured in the first place.
So do you
So at
think
the end
the
of the day,
bigger lever, do you think the bigger lever to pull is the biomechanics lever, not whether you had ice within the first 2 or 3 days?
I will always say the biomechanical lever for this conversation is going to be the more
Okay.
important one, until I see evidence to suggest that that's not the case. I just don't tangibly see how direct application of cryotherapy, no matter what phase of the healing process you apply it in, I just don't see how, other than maybe saving you a day or two and getting you a little bit more comfortable, which can be important, I don't see how that makes a big difference in the long term. Like if it's a very mild ankle sprain and it's just like a tweak of the ankle ligament, there's not really a lot of swelling or bruising, and the pain is like going away during ongoing competition, like it was so mild that you don't even need to take time off during that day, then there's not really any. Of course, I think rehab would be a good idea to prevent it from happening again, but that patient's probably not going to lose much time at all. If it's a moderate or severe ankle sprain where there's considerable swelling, difficulty ambulating comfortably, lots of bruising, dependent bruising underneath the ankle, the typical way that we see ankle sprains that present to the office, then the evidence suggests that cryotherapy might improve your ability to return to sport within a couple of days earlier than if you don't do the cryotherapy, and I'm fine with that. But we're talking on the order of a couple of days. And in the grand scheme of recovering over 3 to 6 weeks, which is how long most of those injuries take to get back to the level of confidence you need to not injure yourself again and continue to play pain-free, in the context of that many weeks, if a couple of days is very important to that athlete, then sure. But usually the couple of days doesn't make a terribly big difference, and the difference that they feel is not that substantial. So even when cryotherapy has the best evidence to support its use, I think how far it moves the needle is quite significant in the sense that we can measure it and it's real, but it's not significant in the sense that it's making a big practical difference for the athlete to athlete comparison.
I was thinking in that video too, I'm like, how deep is that really getting, right? Like, so you're spraying this thing on the leg with a bag on top of it. Like, I mean, let's just say, hey, this was some muscle soreness, like, and there you've got gastroc. So like, how deep are we really getting with this spray, right? Is it just like, is that the equivalent of the little freezy spray that sometimes people spray before an
Yeah,
injection
soccer
or like
players love that thing, man.
yeah. But so I guess yeah, like I'm always going to ask like is it doing what you say it's doing, right? That's the other thing. But let me just go back to the medication part. Do you think that there is some component of the anti-inflammatory treatment that can be contributing to tendinopathy developing? And let's just use patella tendinopathy because that's the most common one we see in our population. Do you know of any evidence that that's what's occurring?
I think probably all tendinopathy, including patellar tendinopathy, is a victim of poor mechanics somewhere else. And the way that I like to explain it to patients and parents are that if you come in and I say you have patellar tendinitis, what I'm communicating is this tendon by your body is being asked to do too much because something else along the kinetic chain is not doing its job and holding up its end of the bargain. And so the analogy is if there's a fire and your smoke alarm is going off, I would hope that your answer to the smoke alarm going off is not to go take out the batteries or replace the batteries to the smoke alarm. I hope your answer would be, let's investigate what caused this to go off. And after we have investigated what caused it to go off, maybe through finding the fire and extinguishing it or decreasing the source of the smoke alarm will go off on its own. That's kind of the typical paradigm that we would approach that analogy. I think tendinitis, tendinopathy, and other overuse injuries are in the same bucket in the sense that if you come in and every time you jump and hop, your knee is hurting, we do our exam, we get an ultrasound, we maybe even verify with an MRI, we see that there's a thickened and painful patellar tendon, and that's the spot of pain, and that's where you're reliably having pain every time you play sports, then that tendon is tasked to do too much because something else along the kinetic chain is not doing its job. And until we address the biomechanical problem, I don't think we'll get at the core of why you're having this pain. I feel less confident in your overall short-term, medium-term, and long-term recovery. I think the regular use of any adjuvant or ancillary therapy, including cryotherapy or heat or anti-inflammatories, is a superfluous factor in the paradigm. I'm not convinced that dedicated use of any of those modalities convincingly alters the experience, the clinical experience in that patient. I don't think it does. I'm not convinced, or I haven't seen evidence that it does some great harm. And I'm not convinced that it does some great help. I think it's just used as an adjuvant modality to assist in ultimately what I think will help, which is changing the biomechanics of how the leg is being used. And so the way that I would specifically address patellar tendinopathy is that in the first stage would be to get you pain-free as quick as possible, which would be a combination of resting. And more recent evidence suggests that heavy isometric holds where you flex the quadricep muscle, activate the patellar tendon, and ask it to just hold a force without moving. So your knee is not flexing or extending, it's just resisting a force. You can do that through like a squat against a wall where you're just not moving and holding it for a period of time. Or you can get on one of those quad machines at the gym and put the weight to something challenging but not dangerous and just hold the leg in partial flexion to resist that. Doing subsequent sets of that is a good way to get pain relief in the short term and sort of retrain. The way that I sort of think about it is that once the problem has led to the patellar tendon being painful, then more proximally, the quadriceps muscles that attach to the patellar tendon have started to fall asleep. So initially what probably happened is that you have poor hip mechanics. So the quad muscle was trying to keep up with it. The quad muscle sort of has kind of given up on this, or it wasn't really active very well in the first place. So you've had poor hip control, you've had poor quad control, and unfortunately your patellar tendon has decided to take up the responsibility of doing all of your cutting and pivoting, and now it's barking at you and it's started to break down and restructure itself because it has been insulted so many times from all the jumping and landing and having to keep up with the job. So when we approach rehab, I think ibuprofen, naproxen, throw whatever you want at it. They might move the needle a little bit, 1%, 2%. Not my main source of trying to get this athlete back to where they need to be. I would start with isometric holds to get the pain under control. And my philosophy is that while you're doing these isometric controls, you are enhancing quadricep muscle fiber recruitment. So you're kind of doing two things at the same time, where you're getting the pain to be better, and that quadricep muscle that's fallen asleep is now getting woken up because you're forcing it to fire, recruit more fibers per second as you're holding that specific isometric hold. And then as that's starting to burn up and you're starting to feel that it's finally working, you can move more proximally and check how is the hip engaging? Are you balanced properly? Are you dipping into dynamic valgus or not? How can we train the hip to fire more more appropriately to take up the task that it's supposed to take up when you're playing sports. That fundamental foundation, kind of like a pyramid from the bottom up, is how I would approach tendonitis and tendinopathy. And I think we're getting distracted by thinking about icing it this many minutes, applying heat at this time, stretching it this way. All of the, even stretching, like it probably helps. But what helps more is loading the tendon, having the tendon move through a full range of motion that it has to control through concentric, isometric, and eccentric. And then after you've gotten that specific quad patella complex to do what you want it to do, going more proximally and finding the real source of the fire, which is likely either hip or core engagement acting poorly, get that up to where it needs to be so that it can take over the job and the patellar tendon can take a right.
Okay, so you're not thinking like, and I'm not saying this at all, but I feel like maybe that pendulum has started to swing to that side of like overuse of anti-inflammatories is, quote unquote, causing tendinopathy to occur. It doesn't sound like that particular needle mover for you, which I agree with. I think what you laid out is a nice approach, realistic approach to like an you have time to recover situation. So let's just call it an off season. This is what I might do for an in-season situation. So 17-year-old patellar tendinopathy, that's got games that still needs to play, still needs to get out there. That can be a little bit, sometimes you give we both do it. We give this biomechanics spiel to the family and they're like, yeah, but he's got a game in 2 days. So like, that's not really going to help us. And not that what I would say next is going to be the 2-day solution, but the concept. So what we'll do, or at least what I'll do in clinic, is I'll consider first like all the things you said, but adding a little bit of dry needling to the tendon to see if we can try to stimulate some benefit, stimulate some response within that tendon. And that is a situation where I'll say, hey, let's try to limit the anti-inflammatories because in theory, we're trying to stimulate some healing response. So I might go to that. I might consider the more aggressive treatments that we do with ultrasound guided needle tenotomy as well. I think what's the name of the particular procedure with the shockwave therapy? Be another, but I think those would be reasonable in season efforts that might be something you would consider not, holding on your anti-inflammatories or at least holding on them close within the treatment time. But still, I see the point, right? It's like you're taking the battery out of the smoke detector with those treatments. But sometimes like that's what you need to do until like you can go put out the fire, now that you've got it contained. But
Yeah.
that's my thought.
I think certainly the idea of introducing, so I think you and I both agree that injection therapies with corticosteroids in the area of tendons is a big no-no. And so we would both ubiquitously avoid introducing any steroid in that area for, completely for justified reasons, as that dramatically enhances risk of tendon injury and tendon rupture. The evidence that there is considerable harm if you're using what's conventionally known as prolotherapy, which would be like some numbing medication with some hyperosmolar dextrose or super concentrated sugar, basically. Those sorts of treatments, it doesn't seem to be that there's much harm associated with that. And there is good evidence to suggest that there could be some short-term and medium-term benefit in terms of pain control and leg function. So I'm totally on board with using those similar to you in the sense of we're trying to get an athlete back on a very strict timetable. But I always have this internal struggle when I'm talking families through that because I know and I cannot ignore that the right answer is that we're in this situation because the biomechanics are poor. And so sometimes I'm like, if this really works for this athlete and they feel much better, even though the evidence is clear that the way they move their body is the reason for the pain, they're going to take away that this guy put this needle in my knee and I felt much better within a week and I could go back to everything. I think there's like a little bit of there's a tension there between the pain control and what the athlete feels helped versus you're knowing that you kind of got lucky in that situation and they're going to be able to salvage the last 3 weeks of their season. But what led to the problem in the first place was something that we have not yet addressed. Because I feel that athletes lose a little bit of confidence. If they get that kind of dramatic pain relief, which sometimes they do, then they're like, well, why do I need to do rehab? I'm not in pain anymore. And so they don't think through like, well, this could happen again later, or if you don't build don't build the foundational good habits now, it can come back to bite you later. And so there's always that tension I struggle with a little bit. And I think that at the end of the conversation, if it's a tendon overuse, whether we call it tendonitis or tendinopathy, two factors led to that. One, poor biomechanics multiplied by volume that's inappropriate for that level of competition. So you're either doing way too much or you're doing whatever, not high volume, but with poor mechanics, or a hybrid of the two. And so if you have perfect mechanics, then you're just doing too much. And what I'm doing is I'm numbing the pain and kind of telling you it's okay to keep doing too much, when the answer is probably that it's not. Like, you have an overuse injury and you have to turn down the volume. But we're living in an era where people don't really are not open to that conversation for a whole host of factors. And so there is a tension that I have where, like, I'm trying to give, certainly nothing I'm doing is causing any harm, and the evidence is clear for that. But there's a tension where I'm not really communicating the message that I think is most important for people to hear.
Okay, let me ask you this. I guess it's two questions. One is, have you ever seen on ultrasound in, let's just say, 18 and below, true tendinopathy other than in the patellar tendon? And the reason why I'm asking that is, do you think this is a classic case of adapting what we would do for an adult to what we would do for a kid, right? So, like, there's lots of areas that an adult might have tendinopathy that they would make the argument it's not because I'm doing sports. Like, I'm 45, I work at a desk and my Achilles hurts, but I'm not doing sports, and they identify tendinopathy, right? Like, so those levers to pull about sports and biomechanics, I mean, maybe the biomechanics is still there, but maybe there's like a metabolic issue that occurs on the adult side that's not really there on the pediatric side. I don't know. And maybe that's why we only see it in the knee, because the biomechanical forces just set the body up for it to occur there.
Yeah, it doesn't occur to me or come to my mind if I've seen a thickened or hypoechoic region of tendon that clearly looks like textbook tendinopathy or tendinosis. I don't think I've seen that in a pediatric patient in a location other than the patellar tendon in the age group that we treat. So I think my answer would be no.
So
Although your point
could you buy that
Yeah, go ahead.
argument that essentially in certain instances there's mechanism by which tendinopathy or tendinosis occurs may be slightly different in the adult, 50 plus, than it is in the 16 and below? Their treatment is, hey, let's do all these interventions, whereas our treatment might be, let's look at the biomechanics.
I think we are muddying the water a little bit by comparing the two, and I'll tell you why. First, if it's a 45-year-old otherwise healthy gentleman who has heel pain or Achilles pain while sitting at a desk, I'm very interested to make sure I got the diagnosis right, because if that person is sedentary, I'm kind of don't care what the imaging looks like. It doesn't make any sense in my brain to be convinced with 100% certainty that that's Achilles tendinitis or tendinopathy. I feel like that setup feels like it's missing something. Like there's a puzzle piece missing.
And that may be
me.
a bad example on my end, but
No, I think it's actually a good example, because I think that sometimes well-meaning adult trained people may be okay with running with that, because they're like, that makes sense as a diagnosis, which I guess, like, if you squeeze the Achilles and it hurts and a patient says it hurts in that spot and you've excluded a tear, then you can call that I think in the adult world you can call that tendinitis. Like, I get why somebody would say that. And I think some people sort of Google or use artificial intelligence and put in those specific exact words, and they get spit out a diagnosis of tendinitis, and they think that's what it is. I can see why that would happen in the scenario you described. But to me, when I'm seeing a patient, and this, even when I was seeing adults regularly, I would still focus on, your story has to make sense for this diagnosis. Like, you have to convince me that you're using this leg too much and or in an inappropriate way. And over time, it has poor adaptations that have occurred at the tendon level that are now causing you consistent pain. If you don't give me that story, I don't feel comfortable in the diagnosis, which is important for me because I need to know the diagnosis accurately to guide treatment the right way. Maybe because then, there's things that masquerade. Like, it could be autoimmune tenosynovitis, which has nothing to do with specifically uses of how you're using the leg. And so if that same example you gave me was like, well, I've actually taken up uphill walking because I read this article that said that cranking the treadmill up and putting it at a low space for 30 minutes a day, like that really is supposed to help. And I've never done that before. And I started doing it. And after 2 weeks, it's really started to hurt my Achilles. And now it like really hurts when I sit down. Okay, now you've given me a good story where that Achilles had been put into eccentric load repetitively over time, something the body was not used to before then. You jumped into doing it. You've been doing it for a while, and now you have pain in that spot. Perfect. Tendonitis in that in terms of a diagnosis under that clinical scenario makes a lot of sense, and I'm okay with that. But if you just not change the way you've lived your life, and now all of a sudden you're having tendon pain in the same spot over and over again, I think the differential, the bucket of what that could be is really broad, and it's pretty narrow to just jump to tendonitis, even though you could kind of connect the dots sort of superficially and make that diagnosis.
What I would wonder about though is sometimes the level of activity in an adult, right? Like, is the equivalent to exercise, like the level of activity that that adult can tolerate is equivalent to exercise in the younger patient, right? So, like, you could maybe make the argument, like, okay, this person got a new job and they had to walk further from their car to the office, right? Like, we don't think of that as exercise, but we certainly have seen people with swollen boggy glute med tendons that you would not have expected to be there, true tendinopathy, tendinosis at that region. Sometimes I'm like, maybe that's a metabolic issue combined with a biomechanical issue. And maybe the approach of PRP shots and different things like that is like a reasonable thought. But then people start saying, well, like, yeah, like my doc gave me a PRP shot and it felt great. So like you're 12, or I guess let's use you're 16 and you have a similar condition. Maybe like we're barking up the wrong tree with that process. I get what you're saying though. I get what you're saying.
I think so. Even that story of like, I now have a new job, I have to park farther and I have to walk further every day. I need that. Like
Hmm.
that has to be there in the history for me to feel comfortable. Like I'm willing to accept that as a diagnosis of a tendonitis being caused by that change in
Hmm.
lifestyle. I think that the threshold that adult tendons have to tolerate those kind of changes in activity in people who are otherwise sedentary is pretty limited. So some people, if they just live the same life over and over again, might not get any discomfort. But if their life changes even subtly and it requires them to do a little bit more, and they haven't been preparing their body in some way mechanically, so they haven't been doing yoga or exercises or whatever, their body might be very sensitive to even a slight change in physical activity within the category of activities of daily living, and then they get pain a couple of weeks later. So I'm willing to buy that. I think in kids, it doesn't happen nearly at that rate because generally speaking, the tissues within the musculoskeletal system of pediatric patients and adolescents is far more resistant, and the capacity for them to tolerate changes in activities of daily living, even if they're sedentary, is quite high. And so a pediatric patient who doesn't play any sports, who goes from middle school to high school, and the high school is considerably bigger, and they have to walk far longer than they used to be able to walk in order to go between classes, go to the cafeteria, etc. I don't think that that's going to necessarily cause tendonitis in that child most of the time, because we're talking about somebody who's between 13, 14, or 15 years old. But in a 40-year-old who is otherwise sedentary, who changes jobs, like you said, and now has to walk considerably, that 40 years of life has changed the way the muscle tendon complex behaves, and it might not be resistant to that change in activity of daily living, where tendonitis then makes sense for that individual. Whereas in the teenager I was talking about, if they came in and they said, now I have tendonitis or now I have tendon pain, I would be really cautious that the only thing that's changed is that they go to a different school and they walk more. I'd want a little bit more than that to be confident that I've made a diagnosis of tendonitis accurately. So that would be
Totally.
kind of the way that I approach it.
Now, I in this scenario, I'm really referring to like ultrasound changes on the tendon in that specific scenario. But just to give you an example of what you just said is, I had a friend call me and was like, "Hey, dude, I'm having this ankle pain." Late 40s, female, and I'm like, I don't know, like I don't know, like I asking like, has anything changed? All the stuff that you're asking about. And then she went to an ortho, and they said it was posterior tib. They call it tib tendonitis. They didn't ultrasound it or anything. And I was like a little bit skeptical. But then she tells me later in the conversation, after she saw someone, that she started bowling. And I'm like, well, you didn't say anything about the bowling part. And I'm like, okay, yeah, like that makes sense to me that you would, be aggravating something. I mean, she went from really not being active to bowling, which I wouldn't think of as super strenuous on the body, but certainly it all made sense at that point
See,
for
and
sure.
now at this point in my way of practice, I like almost like force a patient to stay in the room with me because not only do I want to marry the change in activity level, but I want to marry that to now that you mention it, it does feel worse at the end of bowling.
Hmm.
And I want to marry that to like the shoes that I use for bowling may not be fitting properly. Like I want to capture everything along the pathway to be 100% sure that now this is truly posterior tib tendonitis. And I want to marry that to the exam where you resist the action of the posterior tib. And while it's held in isometric hold in your hand, you kind of palpate along the medial border through the navicular, going up past the medial malleolus, and like, yep, this is posterior tib 100%. I want the patient to tell me, yep, that's 100%. That's the pain. That's what hurt. Doing this hurts. You got your finger on the spot. That's the right spot. If I get, at that point, if I get that good of a history and physical, I don't need any imaging. Now I'm very comfortable with the diagnosis. You've given me the right story for it. You've given the physical exam matches completely accurately with the diagnosis you've given me. And so I now feel confident that we're on the right pathway. And in pediatric patients, like this wraps up kind of like everything we've talked about. When you are a young child and you haven't even quite reached puberty yet, and you're playing a lot of sports or you're physically active, and you have recurrent pain with activity that you're treating with cryotherapy, please consider that there's a whole host of accurate diagnoses that we really want to make in order to guide how you should continue to train and keep you safe that may have nothing to do with just using cryotherapy over and over and over again. And if we did recommend cryotherapy, we would recommend it in a very narrow spectrum that doesn't necessarily act as the treatment to the problem we think is actually going on.
I just wanted to leave you with this last story that I had because so I had a second opinion. I think it was this week or last week, and it was just like a 15, 16-year-old female um, competitive cheer with an ankle injury, right? So she does a round off back tuck, ends the back tuck, just maybe a little bit of exaggerated or over um, dorsiflexion, like didn't fall, didn't twist, didn't feel a pop, nothing like that. Goes to the ED, gets x-rays. They say she has an ankle sprain. Goes to the ortho, the first opinion, say, yeah, you sprained your ankle, puts her from a boot into a brace, and then not really getting better, went to PT, not really getting better, saw me at about 5 to 6 weeks. The first thing I'm asking, I'm like, all right, well, tell me exactly what happened. And then the whole time I'm like, okay, well, when did you sprain your ankle? Like, when did that happen? Like, I think that's such a critical factor, is like the story has to make sense. I'm like, this doesn't, and it's not like, oh, I get it right every time. It's just like, well, you have to physically sprain, twist, turn your ankle for there to be an ankle sprain. So I don't know how we could lead with that as our diagnosis. And it can frustrate me a little bit because sometimes I'm like, I think this is just something that people do for kids, that they're like, well, like ankle 16, like it's probably an ankle sprain. The x-ray's negative, like it's like the in-depth, right? Like to me it was like, well, this sounds like your tibia impacted your and you probably have a bone bruise or impaction injury there that's taking time to heal. Now I didn't know it at the time, and again, I get stuff wrong, but they had an MRI. We looked the MRI up and it's like ligaments are totally fine. The MRI had been after all that stuff, and there was a bone bruise to the tail of her neck, and I'm like, yeah, like that adds up, that makes sense. But I think it's just so easy to try to fit a set of symptoms into a diagnosis that actually doesn't fit the set of symptoms. You know what I mean?
Yeah, and I would agree. Like the other part of that is like an ankle sprain and a peroneal tendon strain are not the same thing.
Hmm.
And that the difference, even though the location of those two structures, depending on where along the tendon you may have strained your foot, if it's adjacent to the lateral malleolus, then they, on exam, it may look puffy and swollen and sort of hurt in the same spot. But it matters to me to get the answer right, because to me, being able to inspire the right rehab program to ensure you adequately improve and not have the injury happen again is going to be very important. So if it's the ligament is sprained, then proprioception and pain control are going to be very important. But if it's a tendon strain, then assessing function and making sure mechanics are important, which of course proprioception will be important, but I probably wouldn't emphasize proprioceptive training quite as much. And those two scenarios are different. And if you're at the elite edges of competition and you want to be perfect, then we want to take care of you perfectly because we want to support that aspiration.
Yeah, I think that that doesn't get done as much on the pediatric side. And I don't think it's for, truly, I don't think it's for lack of knowledge. I think it's just like it is very easy to take a patient who maybe isn't giving you a lot of information and doesn't quite know their body super well, maybe doesn't even want to be there because they think you're going to hold them out of their game. And it's just very easy to be like, yeah, I mean, I've seen the same exact scenario where, it was like Achilles strain or ankle sprain. I'm like, wait a minute, like you don't hurt in either one of those areas. This is like deep to that. Like this is an os trigonum type situation. Like again, it's not like having the perfect diagnosis every time is what I'm trying to say. But like you said, like the approach needs to be very systematic. And as part of that approach, being thoughtful about mechanism, being thoughtful about does the exam match? You want to get imaging when you are trying to confirm what you already expect to see, right? Like that's when imaging is really helpful. And we talk about that another time, but I do think that can cause quite a bit of a stress for families as well. But yeah, I mean, I think that approach is key and only allows you to be better able to get the patient back if you can make a more accurate diagnosis.